Charlie.
Thank you, Barbara. Can you hear me all right? I ask that because with Parkinson's, your voice gets softer over the years. So if you can't hear me, be sure and raise your hand. When you think about it, the brain is an amazing organ in the body. It counts for only 2% of our body, but it is so much more important than that. Look, number represents. Every movement we make, every word we utter, every problem we try to solve, it originates in the brain. Without it, we would be in big trouble. When the brain gets in trouble and begins to have problems, that becomes absolutely needs to be treated as quickly as possible. Having Parkinson's disease, I was diagnosed 21 years ago, and I don't recommend it for anybody. It can make you feel awkward in public like it does right now. It makes us, those of us who have it, we're tired a lot. And you can spend a whole day reading or watching television and you feel tired at the end of the day. It ages and slows us down. One person had a good description of Parkinson's. It's like trying to drive your car over the parking brake. And I'm sure those of you who haven't have had that experience, simple tasks seem to become much more difficult. It's like tying shoes and buttoning buttons. It became a major time-consuming. Sure. One thing that you see is loss of executive function, which is the ability, having executive function enables you to plan and to organize things. You go into my study today, it looks like somebody set a bomb off in my study. But fortunately, we have made major strides in the treatment of Parkinson's. And we are so lucky to live in a community in which Parkinson's is attacked on 2 or 3 fronts. One here at VCU in Richmond. The center that our speaker today has played a key role in bringing it to Richmond. And the people that come with it, we are lucky to live where we do. Treating someone with a brain injury requires skills and expertise that have developed over the years. And today's speaker, Leslie Cloud, is one of those stars in the Parkinson community for what she's doing for those of us that don't have it. I mean, those of us who do have it. She is originally from New England. She did her undergraduate degree at Emory University in Atlanta, which has a very fine Parkinson's program. And she did her internship at, I'm losing my thought here. Anyway, she came here 11 years ago, and she's been a major factor in the successful development of the center in the West End. Those of you who go out on Broad Street in the West End will see the VCU tower next to the car wash, and that is where the Parkinson's is. And again, we are very fortunate to have one here. So let me turn the program over to our speaker, Leslie Cloud.
is very modest, and he failed to mention that it was actually due to his work along with David Reynolds that the VCU Parkinson's and Movement Disorder Center was even founded. And their story and their dedication was a big part of why I chose to come here. So thank you, Charlie. And he has continued to be a force for good in the local Parkinson's community. So thank you for inviting me to speak today. I'm happy to be here. And as a historian, Charlie, I think, chose a great topic for us to talk about today, which is a journey through the history of Parkinson's disease. We're going to start at the beginning and go all the way through to present day and then speculate a little bit about the future. So feel free along the way to jump in. If you have questions, you don't have to hold them until the end. I don't mind taking questions along the way. So we're going to begin at the beginning. So there are very brief mentions of Parkinson's-like symptoms in ancient writings dating as far back as 2000 BC, but most people would agree that really the first in-depth medical description of the disease was in 1817 when James Parkinson wrote his essay on the shaking palsy. So James Parkinson was a surgeon and an apothecary in London, and he was the son of a surgeon and apothecary, so he was sort of born into the medical profession. And he wrote this essay, which was a description of 6 cases of Parkinson's disease, 3 of which he never even met. He observed people from a distance on the streets of London who had these symptoms and described them in magnificent detail. And he was really very astute, very keen with his observation skills, and he really described a number of the motor and non-motor symptoms that we now know to be a part of the Parkinson's disease process. So here's a quote, and actually before I go any further, let me just learn a little bit about the audience, because it'll help me as I kind of frame this talk. So how many people in the crowd, raise your hand if you either have Parkinson's disease or know someone with Parkinson's disease and have some familiarity with it? Okay. And then raise your hand if you are a working or retired medical person of some sort. Okay. And then raise your hand if you know really nothing about Parkinson's disease at all. Okay. Okay, that helps me. So in this quote from James Parkinson's essay on the shaking palsy, he describes some of the key physical features of the disease that affect movement. So he says that there is involuntary tremulous motion with lessened muscular power in parts not in action and even when supported. So he's describing the resting tremor that occurs in Parkinson's disease when people are not doing something with their hands, they're just resting, maybe even the hand is supported against gravity, resting on a table, but it still shakes. And then he says there is a propensity to bend the trunk forward, so the stooping posture that we often see. And there's also the tendency to pass from a walking to a running pace. This is describing a problem called festination of gait that sometimes happens in people with Parkinson's. And lastly, he says, yet the senses and the intellect remain uninjured. So he really describes many of the key features that affect movement and comments on the fact that the intellect is preserved. Now, in the rest of his essay, he also talks about lots of other features of the disease. This is just a quote, but he really was able to observe a lot in those 6 patients, and his description is not that different from the descriptions you read about in textbooks today. So then it's about 50 years later when a French neurosurgeon named Charcot makes several key additional contributions to the medical community's understanding of this disease that James Parkinson had called the shaking palsy. So Charcot, number one, picked up on another key feature of the disease that James Parkinson had missed in his description, and that is what's called bradykinesia, or slowness of movement. So Charcot describes bradykinesia by saying, their problem relates more to slowness in execution of movement rather than to real weakness. In spite of the tremor, a patient is still able to do most things, but he performs them with remarkable slowness. Between the thought and the action, there is considerable time lapse. Charcot also noted that there were at least two distinct types of Parkinson's disease. There was what he called the tremorous type, where people had a lot of shaking, and then there was the akinetic rigid form, where people may not shake at all, but they're very stiff and they're very slow. And because of that observation, he changed the name of the disease. He did not like the term shaking palsy because he realized that not everybody with the condition shakes. And so he decided to rename this Parkinson's disease after James Parkinson for his original description 50 plus years earlier. In a fascinating turn of events, Charcot also was the first to treat patients with Parkinson's disease. This is truly remarkable because this is decades before it had been discovered that dopamine was a neurotransmitter and that dopamine was deficient in the brains of patients with Parkinson's disease. None of this was known yet. And yet Charcot was able to find some natural substances that had anticholinergic properties and that were sort of the precursors of modern day dopamine agonists that had some therapeutic benefit for patients with Parkinson's disease. So Charcot actually began treating patients for their tremor and other movement-related symptoms. So then, fast forward nearly 100 years to 1960 and the years just prior to that, when it's discovered that dopamine is a neurotransmitter and that dopamine is deficient in the brains of people with Parkinson's disease. And this leads to the thought in the medical community that we might be able to treat this disorder if we can replace that dopamine. And so it was in 1961 when a clinician researcher named Berkmeyer injected for the first time a patient with Parkinson's disease with IV levodopa, which is converted into the brain, converted in the brain into dopamine. And it was nothing short of a miracle. In his own words, he describes bedridden patients who were unable to sit up, patients who could not stand up when seated, and patients who, when standing, could not start walking, were able to perform all of these activities with ease after levodopa. They could even run and jump. So this was the first major breakthrough in Parkinson's disease treatment, and to this day, it is really still the most monumental.
Is this the movie?
Robin Williams, Awakenings. So, great movie. So the question was, is this what the movie Awakenings with Robin Williams was about? Sort of. So in that movie, they were focusing on a post-epidemic form of Parkinsonism. There was an epidemic, a viral epidemic, that caused something called encephalitis lethargica, which caused patients who recovered from the virus to then go into like a catatonic state where they couldn't talk, they couldn't move, they were just completely like a stone in a chair or a bed, and they remained that way for years. And there was a very famous neurologist named Oliver Sacks who tried giving levodopa to those patients on the kind of working theory that it might help them, and in fact it did. And so that movie was about encephalitis lethargica, not idiopathic Parkinson's disease, but they're very similar in the way that they look and the way that they respond to levodopa. And that's a fantastic movie. If you haven't seen it, I highly recommend it. Great movie, and it really was Robin Williams at his finest. So in the 1960s, we get the discovery that levodopa is nothing short of a miracle for patients with Parkinson's disease. And it was in 1975 that levodopa was commercialized in a pill form and was then available to the public in mass. And over the next 30 years, so between the 1960s and the 1990s, we saw a steady stream of drug development, and we got the 5 major classes of medications that we still use today to treat Parkinson's disease. All of these drugs in some way work to raise dopamine levels in the brain of patients with Parkinson's disease. They do it through different mechanisms, but they all essentially lead to more dopamine being available in the brain for people with Parkinson's, which helps in turn restore more normal movement. So then the next major breakthrough after levodopa being discovered is generally thought to be the discovery of deep brain stimulation surgery for the treatment of Parkinson's disease. So this was the result of work by a French neurosurgeon, Benabide, who was the first to successfully perform DBS surgery on a patient with Parkinson's disease to treat the tremor specifically. So the very first case was targeting the anatomic part of the brain that is responsible for the tremor. And so he was able to do this safely and successfully treat tremor. For those of you who are not familiar with deep brain stimulation surgery, this is a procedure in which a small electrode is implanted into the part of the brain that is responsible for generating the abnormal movement, in this case tremor. And then a power source for that electrode is implanted under the skin of the chest. I'm not sure if I have a pointer here. Yeah, I do. So then the battery power source goes under the skin of the chest like a pacemaker, and they're connected with a wire. And so you're able to deliver low levels of electrical stimulation to the affected part of the brain, and that disrupts the abnormal electrical circuits in the brain that generate the tremor and drive the tremor. And so you're able to successfully treat the motor symptoms of the disease with electrical stimulation. So then this led to approximately 10 to 15 years of pretty intense scientific work trying to understand the circuitry of the brain, particularly the parts of the brain that are responsible for the movement problems in Parkinson's disease. And the information learned about those circuits led to the realization that deep brain stimulation would be even more effective for Parkinson's patients if we put it in a different place than Benabide did originally. So Benabide was able to treat tremor, but not the other aspects of the disease. But over time, we realized that if you put the stimulator in other locations, like the subthalamic nucleus or the globus pallidus, that you could still treat the tremor, but also treat the slowness of movement and the stiffness and some of the posture problems. And so over time, we saw steady improvements upon the original approach to DBS. And by the late 1990s, this had become standard of care pretty much everywhere for patients with advanced Parkinson's disease who were not getting adequate response to medication alone. So then the next big breakthrough was the discovery of the first of eventually many genes that were responsible for inherited forms of Parkinson's disease. And in the years that followed this, there was, again, an explosion of research into the genetics of Parkinson's disease. And we learned that there is, not one, but many genes that can be a cause of Parkinson's disease, but only in a minority of patients. And we'll talk more about that later. So most people with Parkinson's disease don't have a genetic cause. Only 15% or less do. But we now know a lot about that 15% and the different genes that can be causative in certain families. So that brings us up to the 21st century, which we're going to call the present. And we're going to talk a little bit about kind of where we are now with regard to medications and surgery and genetics. So we now know that there are many genes that can have mutations in them that can cause Parkinson's disease in some individuals. And we are continuing to learn more and more every day. Recently, one of the biggest factors in our expanding knowledge is a study called PD generation, which is being spearheaded by the Parkinson's Foundation, and it provides very thorough and comprehensive genetic testing for all of the relevant Parkinson's disease genes free of charge to anybody with Parkinson's disease. And so they have already done genetic testing on more than 20,000 individuals with Parkinson's disease and are continuing to expand to other countries and continents so that we can really try to understand the genetics of this disease as best we can. So lots of different causative genes, the most common of which is called GBA, but there are many others. And typically the genetic forms most likely or most commonly affect people with young onset PD. So when people are very young, like Michael J. Fox, when they get their disease, they're more likely to have a genetic form. Whereas when people get this in their 70s, which is the most common age, it's less likely to be a genetic form and more likely to be what we call idiopathic PD, which means we don't know what caused it, it just happens. Also in the modern era, we now have very reliable and commercially available biomarkers. So a biomarker is anything that we can measure in a person that tells us something about their disease state. In this case, these are tests that can tell us very objectively if someone has Parkinson's disease or if they are at risk to develop Parkinson's disease in the future. So we can even pick up at-risk individuals before they manifest their clinical Parkinson's disease. So the three biomarkers that are available on the market today are the DAT scan, which is a kind of fancy type of CT scan that is able to image the number of dopamine transporters in the brain. It should be normal in someone without Parkinson's disease. The number should be reduced in someone who has Parkinson's disease. And this is a test that's now available pretty much everywhere at every major hospital and medical center. We also have something called a SIN1 test, which is a skin biopsy. Just like the skin biopsy you get when you go to the dermatologist and they see a spot that they're worried about and they take a little tiny punch biopsy in clinic, same exact thing. And then that small skin biopsy is sent to a lab where they dissect out the tiny little nerves that are in the skin, and then they examine those nerves looking for an abnormal protein called phosphorylated alpha-synuclein, which should not be present in the nerves of a healthy person with no Parkinson's disease, but it is present ubiquitously in those who do have Parkinson's disease. And this is a very sensitive test. It picks up 96% of people with Parkinson's disease, even in the very early stages. And then the most recent biomarker to become commercially available is called the alpha-synuclein seed amplification assay. So this test requires that you have a test called a spinal tap, where we put a needle into the lower back to pull out some of the spinal fluid that circulates around the brain in the spinal cord. And we are able to take that spinal fluid and look for clumps loss of that abnormal protein called phosphorylated alpha-synuclein. And it is present in the spinal fluid of patients who are going to go on to develop Parkinson's disease but haven't done so yet, as well as in people who have, manifest Parkinson's disease. So we now have all these tools to help us with the diagnosis and also to pick up patients earlier and earlier and earlier, maybe even before they're symptomatic. The list of FDA-approved drugs to treat the motor symptoms of Parkinson's disease has exploded in the last 15 years. So I came here in 2011, and when I came here, this list had 11 drugs on it, and today it has 22, okay? So in the world of drug development, that is a tremendous number of new drugs and new options for treating the motor symptoms of Parkinson's disease. So it's been a good 10 to 15 years in that regard. However, all of these drugs just work to treat the symptoms of the disease that affect movement. They do absolutely nothing to address the underlying problem in the brain or to slow the disease progression or reverse the disease process. These are not curative in any way. They are just symptomatic treatments. We'll come back to that concept in a minute. I do want to take a minute and talk about the 3 most recent drugs to get FDA approval in the United States, because they are each in their own way real game changers. And really, I think for a lot of patients living with Parkinson's disease, these 3 drugs are answered prayers in many ways. So I want to talk about each one a little bit. So one of them is a new oral version of levodopa. So we're still talking about levodopa, but it is a much more modern and sophisticated method of making a pill to deliver the levodopa in a way that is much longer acting. So if you talk to any patients with Parkinson's disease, they will tell you that while levodopa is wonderful in what it does for them, it does not last very long. And it has taken us decades to figure out how to get levodopa in people in a way that will work for many, many, many hours. So the unfortunate reality is that up until now, most people with Parkinson's disease have to take a lot of pills every day. They're taking levodopa sometimes every 1 to 2 hours if they've been living with Parkinson's disease for a long time, and it's exhausting and it's overwhelming. So this pill works by, first of all, it's a capsule, not a pill. I should be more specific. But inside the capsule, there's immediate release levodopa that kicks in right away, just like the old-fashioned levodopa. But then there are these little beads which have mucoadhesive technology. So what that means is that when you swallow them and they get into the part of your GI tract where the medication is absorbed, the little beads stick to the lining of your GI tract. They stick to the mucosa that lines your GI tract like a barnacle would stick to your dock. And it stays there, stuck, for 8 to 10 hours. And while it's stuck there, it's slowly releasing long-acting levodopa into the system. And so you end up getting, with one dose, anywhere from 8 to 12 hours of symptom control. And so we have patients who were taking medication every, sometimes 1 to 2 hours in extreme cases, who are now taking medicine once when they wake up in the morning, once when they go to bed at night, and maybe once smack dab in between, which is a huge improvement in quality of life. So this one is a very welcome game changer. The next one is called Vyalev, that's the brand name. This is a subcutaneous levodopa infusion. So if you know anyone with diabetes who has an insulin pump, this is the equivalent for a patient with Parkinson's disease. They place a small sticker on their skin. That sticker has a tiny little needle on the underside that goes just underneath the skin. It doesn't go deep. And They wear a very small, it's the size of a cell phone, infusion pump that infuses the levodopa directly under the skin, and then it gets absorbed into the bloodstream. You can wear it 24 hours a day, and in the studies, it shows that you get constant levels of the levodopa in the blood around the clock. And it does not matter what you eat or when you eat, because it's not going through the GI tract at all, it's going directly into the bloodstream. We're able to keep patients medicated adequately around the clock. And then the other, and the newest approval was for another subcutaneous infusion. It works in exactly the same way, only instead of it being levodopa, it's a dopamine agonist called apomorphine. This one is not worn around the clock, 24 hours a day. It's only worn for 16 hours a day. So you wear it during the waking day when you're up and at 'em, and you take it off at night when you go to sleep. But it is extremely effective in controlling people's motor symptoms, and it typically enables you to dramatically reduce the amount of levodopa that they're taking. And so this is a nice option for people that have a lot of side effects from levodopa, because we can control their motor symptoms continuously throughout the day with less levodopa on board. So these three are major game changers, and they're all brand spanking new. So the other big recent advance is that the world of deep brain stimulation has become more and more sophisticated, and we now, just in the last couple of months, have in the United States the first closed-loop deep brain stimulation system for Parkinson's disease. So modern deep brain stimulators, those electrodes that we implant in the brain, have the ability to sense and record brain activity around the electrode. And we are smart enough now to know that certain types of brain activity correlate with certain types of symptoms of Parkinson's disease. So these new closed loop systems are able to monitor what's happening in real time in the patient's brain and adapt the way that it's stimulating the patient to address those symptoms as they're evolving and changing throughout the day. And so we now no longer have sort of constant stimulation at a certain level that never changes. We have ever-changing and evolving levels of stimulation and types of stimulation that's driven by what's happening to the patient in the moment. So this is, I would say, the kind of third kind of huge breakthrough. And this is just the beginning of the world of closed loop deep brain stimulation. So that kind of catches us up to where we are in the present with our treatment. We have this whole arsenal of medications that work to treat the motor symptoms of the disease by increasing dopamine levels in most cases. We have surgical treatment options in the form of deep brain stimulation to treat the motor symptoms. And we're learning more and more about what actually causes the disease, both in terms of genetics and also pathophysiology. But the one thing I've left out, for good reason, because it doesn't exist yet, is any type of treatment approach that really addresses the underlying problem and either slows disease progression, reverses the disease altogether, anything that would be anything more than a symptomatic treatment. So that brings us to this transition between the present and the future. So before we talk about the positives on the horizon, I have to unfortunately point out a potential problem that I think worries many of us very much. So it is expected that over the next 25 years, the number of people living with Parkinson's disease is going to double. Furthermore, the number of specialists who are trained to take care of patients with Parkinson's disease and the number of researchers out there who are doing the work to try to advance the field continues to shrink. And when you put those two things together, we are headed for a real crisis, a real international public health crisis. This is a huge concern. On the flip side, on the bright side, we are finally at a point with our understanding of the disease that we are developing drugs that address the underlying disease mechanisms. At the present time, these are all in very early stage clinical trials in humans. So clinical trials take place in 4 phases. There's the first in human studies that are phase 1, and they're usually done on healthy volunteers who don't have the disease of interest. Then there are phase 2 trials, which are done in a small number of people who have the disease of interest, and we're really just looking at safety and how their body interacts with the drug, how it's absorbed, how it's metabolized. We're not really looking at does it work very well yet. And then we move to phase 3, which are the very huge multi-center clinical trials that enroll hundreds or thousands of patients that really try to establish, does the drug work and is it safe in a more definitive way. And then after a drug is approved by the FDA, we enter phase 4 trials, which are the aftermarket long-term studies that just collect long-term data after a drug is commercially available. So most of these disease-modifying strategies are in phase 1 or phase 2 trials. None of them have made it to phase 3 yet, but some of them are inching closer. So we now know a lot about what's going on in the brains of patients with Parkinson's disease and what's causing the problems, and it's not as simple as just not enough dopamine. So there is, in any given individual, several things that are happening, and they all kind of converge together to cause loss of brain cells or cell death. And specifically, it's the brain cells that produce the dopamine that are responsible for the motor symptoms of the disease, but other cells are involved too throughout the nervous system, and they cause other problems, like problems with cognition, problems with mood, problems with sleep, etc. So we're focusing on mainly the motor symptoms today, but just keep in mind that it's much bigger than that in reality. So we now have drugs in development to attack each piece of this puzzle in the nervous system. So inflammation, for example, is known to be a real part of the disease process. So we have trials that are looking at new compounds to treat the inflammation in the brains of people with Parkinson's disease. There's that abnormal protein called alpha-synuclein that likes to clump up and cause problems for cells. And so we have trials looking at compounds that either reduce the production of that abnormal alpha-synuclein or that help the cells clear it faster and get rid of it. And we even have vaccine trials that are essentially stimulating the person's immune system to attack the alpha-synuclein and not allow it to clump up and disrupt cells as much. So there's a number of different trials looking at ways to reduce this abnormal alpha-synuclein. We have some studies that are looking at ways to just keep the cells alive and happy and healthy for longer, to keep them from going through what's called apoptosis or cell death. And then we have a whole line of work that's looking to replace those dopamine cells that are dying off. And that's what most people, I think, are excited about, because these are your stem cell studies and your gene therapies. So this is sort of 2 ways to replace those dopamine producing cells that are dying off. So with gene therapy trials, to kind of describe what these look like right now, this involves a surgical procedure where you're infusing the gene therapy directly into the part of the brain that needs to receive it. And this usually involves using what's called a viral vector. So viruses we're all familiar with, we all get them on a regular basis. Viruses are able to get into your body and essentially hijack your body's cells and inject their genetic material into your body's cells and make you sick. There are some viruses that can be injected into the human body that don't make you sick, and so that's what they use in these studies. But they're taking advantage of viruses' ability to get into the body, hijack your cells, and inject their genetic material into your cells. So in these studies, they take an adenovirus that's not one that's gonna make you sick, and they put the genetic material that they wanna get into your brain cells in that virus. That virus is then infused into the part of the brain that we're targeting, and it puts its DNA into those brain cells that are there in your body. And then that DNA gets incorporated into the DNA of your cells and becomes functional, and it starts to enable your cells to produce dopamine again when they didn't before. This sounds like science fiction, right? I mean, it just sounds wild, but people have done this successfully. That's the concept behind the gene therapy trials. We infuse something that hijacks the cells that are still in there and that are still alive, that are not producing dopamine, and we turn them into dopamine producing cells. The other approach is to just replace the cells that are dying or that have already died. And so that involves infusing stem cells directly into the brain. So stem cells are cells that are undifferentiated. They haven't become what they're meant to be yet, and they have the potential to become just about anything. They can be coaxed into becoming different types of cells. So in the stem cell studies, we're taking stem cells from a source, and the sources are different. Sometimes it comes from the individual's own body. We take cells from their body and turn them into stem cells, and then turn those stem cells into the type of cells we want them to be. And this is all done in a lab, and then we put those cells back into their body. Sometimes it comes from another human donor. But again, this is typically going to require a surgical procedure. The cells are being infused into the part of the brain where we want them to live, and then they take up residence there and become functional and start doing the work of producing dopamine. So these studies, and there are several, I mean, this slide lists all the different trials that are going on right now, have been shown to be reasonably safe with no major adverse events in small numbers of patients, with mixed results, but enough promising results to, still be plugging along the development pipeline. So it's entirely possible that in the future, Parkinson's disease will look like a cocktail, right? Parkinson's disease treatment will look like a cocktail. You'll have your regular medicines and your deep brain stimulation that we have today to treat any motor symptoms that do arise. But at the time of your diagnosis, or even before your diagnosis, when we use those biomarkers to identify that you're at risk, you maybe get your immunotherapy targeted at alpha-synuclein to slow down the accumulation of abnormal alpha-synuclein, which is toxic to your cells over the long term. And maybe you get put on a cocktail of medications to treat inflammation and to prevent cell death. And then maybe early on in the disease process, you get a procedure to deliver either gene therapy or stem cell therapy to replace those dopamine cells that you need to maintain normal movement. And so what we may end up seeing is that the field evolves from just treating motor symptoms of the disease to actually addressing all of these different pieces of the puzzle. So to kind of round this out, I just want to refer you to a fairly recently published book called Ending Parkinson's Disease, A Prescription for Action. This was written by a few of the key thought leaders in the field. And in this book, which is intended for, the general public to read, this is not like a scientific publication, this is written for a general audience. The authors really outlined what they see is 25 things, 25 steps that we all collectively need to do in order to end Parkinson's disease once and for all. So, this is their roadmap to help us eradicate the disease altogether. And to kind of summarize their roadmap, they recommend a PACT, P-A-C-T, for ending Parkinson's disease. And that stands for prevention, advocacy, care, and treatment. And we'll talk a little bit about each one of those. But starting with prevention, they recommend that we all lobby to make sure that paraquat and trichloroethylene are banned everywhere. Paraquat is a pesticide, trichloroethylene is an industrial solvent that's used all over. And both of these are the strongest environmental risk factors for the future development of Parkinson's disease. They also recommend that we all do our level best to protect the next generation from getting Parkinson's disease by not only banning these known environmental risk factors, but making sure that we're drinking clean water. Especially if you're drinking well water, getting your well water tested to make sure that it's free of any harmful substances. Breathing fresh air, eating healthy foods, so making sure that if you're using produce that you're washing it well to get the pesticides off, or even better, buy organic so that there's no pesticides on your produce. Reduce your risk at work, so if you are in the military, or if you are in a field that requires you to work with some of these harmful chemicals like trichloroethylene, wear the appropriate protective gear. Wear the gloves, wear the masks, wear the protective garments so that you minimize your exposure. Exercise. We know that exercise slows the disease process. It's neuroprotective. We should all be exercising throughout our entire lives. Eat well, eat a Mediterranean diet. We have several studies that show that people who eat a Mediterranean-like diet, and the more Mediterranean-like it is, the better, are less likely to develop Parkinson's disease in the future. So we should really all be eating a more Mediterranean-like diet. And enjoy coffee liberally. Multiple studies have shown that people who drink coffee are less likely to get Parkinson's disease. So it's the one vice you're allowed to have, and it's actually good for you. And then avoid activities that are likely to lead to concussions, because we know that recurrent concussions and head injuries are also a very well-established risk factor for the future development of Parkinson's disease. So, football, boxing, probably shouldn't do that. So that's the prescription for preventive action to try to reduce the numbers in future generations. So moving on to advocacy, they recommend that we all call our political representatives and lobby for more funding for Parkinson's disease research, Parkinson's disease care. They also recommend that anybody living with Parkinson's disease be willing to share their story and stay informed and keep up with what's happening, in the research arena, and support those research efforts, either through funding or volunteering or spreading the word to other people about the importance of research. So then the sort of second, third part of the PACT are care and treatment. So they recommend that everybody who has the ability to do so visit a center of excellence where you can have access to clinical trials and state-of-the-art care. They suggest that you demand to receive the care that you want and deserve. So again, contact your government representatives, demand that they hear patient voices and consider patient voices in how Medicare chooses to spend their money, for example. And we want to make sure that we expand Medicare's coverage of telemedicine, not shut it down like they're trying to do, because not everybody lives near a center of excellence. A lot of people are living in states where there's not a movement disorders neurologist anywhere around. The entire state of Wyoming has no movement disorder specialist, right? So telemedicine is essential. And Medicare's trying to shut it down and not pay for it anymore, which is a crime. And then we should all learn more about Parkinson's disease so that we can educate others and, advocate. And then lastly, treatment. So part of the prescription is to join a clinical study if you can. If you don't live near a center that's doing research, participate in a research study from home. There are options to do that through, for example, the Michael J. Fox Foundation. You can join the Fox Insight database cohort where they send you surveys at home for you to complete. And you do that serially over many years, and as a result, we learn a lot that helps us understand the disease better and develop new treatments. And then think about your family history. Think about genetic testing, because you can now get genetic testing for free through the PD Generation study. So this is their prescription for working toward a world that is without Parkinson's disease. Just a quick plug for our VCU Parkinson's and Movement Disorder Center annual Patient Education Day. We do this every year. This year, our Education Day is on April 12th. It's a Saturday. And our theme for this year is patient empowerment. We have 3 speakers. I am one of them, but I have to say I'm the least exciting of them. The real exciting speakers are Dr. Daniel Corpos, who's coming to us from Chicago. He's on faculty at Northwestern University. He is a very famous researcher and physical therapist who did all of the pivotal clinical trials that have taught us that exercise is important for patients with Parkinson's disease, what the impact of that is, and he did all the studies that let us know what the best types of exercise are for patients with Parkinson's disease. So he is really the Parkinson's disease exercise guru, and he's gonna talk about all of the data and how that should impact what people with Parkinson's disease should be doing in the way of exercise. And then we have Dr. Antonio Abate coming from the University of Virginia. He used to be on faculty at VCU, he's now at UVA, but he is a cardiologist, but he is a master clinical trialist and knows so very much about clinical trials, and he's going to be talking about how, as a patient, you can go about, number one, understanding how clinical trials work, but also how to go about deciding if you should participate in any one particular clinical trial versus another. So how to vet a clinical trial and decide if it's a good trial to enroll in, how to vet an investigator and decide if you want to enroll in a trial with that investigator. So the goal of his talk is to empower people to feel confident and comfortable participating in a clinical trial or not. And then I'll be talking about how to seek and consume high quality, trustworthy educational information. The internet is an amazing tool, but it's also sometimes a dangerous thing. And so we'll be talking about where you can go on the internet to find the information you're seeking and that you know you can trust. So consider registering and bring a friend. If you have any interest in learning more about opportunities to participate in clinical trials in our area, you can contact Gina Blackwell at this email address or this phone number, and she will help try to find a trial that matches what you might be looking for. And with that, I'm going to stop talking and take any questions that you might have. So let's see. We have a
What is ataxia clinic? What is that? Ataxia.
Okay, so, did everybody hear the question, or should I repeat the question? Okay, so the question was, what is ataxia clinic? So, ataxia is a kind of general word that describes a problem with movement and coordination. So, patients with ataxia are uncoordinated. They may have uncoordinated hands and legs so that they drop things, or they kind of struggle, to do things that require a lot of coordination, like buttoning buttons. It may also impact their walking. They may have uncoordinated walking, where they might have trouble walking in a straight line. They might kind of veer or run into things. So that's what ataxia means. It's not a specific disease. It's a neurological set of symptoms of uncoordination that can be caused by many different diseases. And many of those diseases that cause ataxia are genetic. Not all of them, but many of them are, and then some of them are acquired. But patients with ataxia have unique needs, and in an effort to better meet those unique needs, many centers have dedicated clinics just for patients with ataxia, where you can see an ataxia expert, a neurologist who knows about all the diseases that cause ataxia, but also physical therapists that understand how to treat ataxia, speech and language pathologists who know how to treat the speaking and swallowing manifestations of ataxia diseases. So an ataxia clinic is a clinic that has all the specialists that are needed to care for people who have ataxia, which may be due to any number of diseases. Just for the record, Parkinson's disease doesn't typically cause ataxia. So those are it's a different group of neurological diseases.
One quick question. Hopefully it's not going to be quick. Right here.
Thank you. Okay, I was like,
Yeah. How are recent developments in Washington affecting research, training, just for VCU, let alone the general field?
okay, so the question was, how is the current situation with the federal government affecting life as usual at an academic medical center like VCU? Yeah, so I'm choosing my words carefully. So it's a real bummer. Grants aren't getting reviewed, right? So, just my personal experience. I have one grant for $1.4 million that is sitting at the National Science Foundation, languishing. The group that was supposed to review it around January couldn't work, and so they couldn't meet to review grants, and we got a message that it wasn't being reviewed, and there's no idea when it's ever going to be reviewed or if it's going to be reviewed. I have another grant in the same situation at NIH, and so federal funding, which we all rely on to do this research, has all but come to a grinding halt. That has made the ability to get grant funding from nonprofit organizations like the Michael J. Fox Foundation a lot harder, because now those grants are much more competitive because nobody's getting any federal funding. And so it's harder to get money to do research because of that. So the research world is in a real crisis. Furthermore, we're being told crazy things like you have to stop doing telehealth next month, when most of our patients don't live locally and we're taking care of them through telehealth. So, it's not good. to put it politely, it's not good. I think we're all trying to convince ourselves that it's temporary and that things will turn around.
At a present state of information, is Parkinson starting in the brain or elsewhere?
That is such a good question. So the question is, does Parkinson's start in the brain or does it start elsewhere? I don't know, and I don't think anybody does, is the short answer to the question. This is a hot topic, and it has been for a long time. So about 20 years ago, the discovery that the same problems that I described earlier that occur in the brains of people with Parkinson's disease, it was found that those same changes occur in the nerve cells outside the brain of people with Parkinson's disease. So if you look at the spinal cord, if you look at the peripheral nerves, if you look at the enteric nervous system, which is the nervous system that lines your GI tract and controls your gut motility, all those nerve cells are affected too. So we had this realization a couple of decades ago that this is not just a brain disease, it's a multi-system neurological disorder that affects the entire body. We also discovered that it seems like the GI tract nerve cells might even be affected before the brain, and that led to the theory that maybe this problem starts in the gut and then travels to the brain. There were other studies that suggested that it was more likely that the problem starts in the brain, maybe due to exposure to something in the environment through the mouth or the nose. So, maybe some sort of infectious agent or something. So there were all these theories floating around about 20 years ago that at the time were quite controversial because historically we always thought of this as just a brain disease. Over the last 20 years, there's been a tremendous amount of work trying to answer that question. And the truth is we still don't know for sure. The truthful answer, I think, is that what we're gonna find over time is that there is no one answer. For some people, it might be that the process starts in the brain. For some people, it might be that the process starts in the periphery. And that might explain why there's so much variability in how patients with Parkinson's disease present and how symptoms evolve over time. So it's a hot topic that we don't quite understand yet, but 20 years ago, the people who said maybe PD starts in the gut were considered to be lunatic fringe. And now almost everybody knows about that hypothesis, right? And it's no longer lunatic fringe. So ask me again in 20 years, and maybe I'll have an answer for you.
What does the age risk profile look like?
Excellent question. What does the age risk profile look like? 74 years of age is the most common age of onset. In general, the longer you live and the older you are, the more at risk you become. This is a disease of aging, predominantly. That being said, it can occur at any time, including very, very young patients. So we do make a distinction if someone gets Parkinson's disease in their early 40s or before. We call that young onset Parkinson's disease because that is in many ways a very different entity than the typical type of Parkinson's disease that strikes in your 60s, 70s, 80s, 90s. So the typical presentation is someone in their 70s, early 70s. The baby boom generation, exactly. I think there's someone in the back.
One more question. Yes, I have kind of a two-part question. The genetic forms of Parkinson's disease that you described in your presentation, has there been any work done with genetic editing in those people? And then the second part sort of relates to what you just talked about, the young onset or early onset Parkinson's. Do you consider that a separate, almost a separate disease entity, and is it treated in a different manner?
Two excellent questions. So the first one's a little easier to answer because it's unfortunately a no. All of the gene studies are really targeted at essentially modifying brain cells to make them dopamine producing cells. Or there are some clinical drugs that are in development that specifically would benefit people with particular genetic mutations, but we're not at the stage of gene editing yet, like with muscular dystrophy, for example, where you can, treat some forms of muscular dystrophy, cure them actually, with gene editing. So we're not there yet. The second part of your question, remind me the second part of your question.
The early onset.
Correct, got it.
Are they a separate sort of entity, and therefore you approach their treatment in a different way?
So the young onset patients are very different in many ways. Number one, as I said before, they're more likely to have a genetic form, but they present differently too. So the young onset patients tend to present with what's called hemidystonia. So on one side of the body, they have a lot of muscle rigidity and stiffness and pain associated with that. So the young onset folks often present not to a neurologist, but to an orthopedist because they've got knee pain or hip pain or shoulder pain because one side is so stiff, it puts stress on the joint, they get a lot of joint pain. And then what we find after we diagnose them and we start them on treatment is that the young onset folks often require high doses of medication to relax that severe hemidystonia, but they are unfortunately much more vulnerable to the development of levodopa-induced dyskinesia, which is the involuntary wiggly movement that you see Michael J. Fox is plagued with. He had young onset PD. And so it's a real nightmare for the physician who's trying to control their symptoms because you finally get them on enough medicine to relax the side that's stiff and painful, and then they've got just out of control dyskinesia. So it really does behave differently. And requires kind of a whole different approach sometimes to managing the symptoms. We still think of it under the same umbrella. We don't think of them as totally separate diseases, but in many ways they are. I mean, there's a lot of people who would argue that we should be talking about Parkinson's diseases and not, one disease, because we lump a lot of things together under that umbrella that can be quite different.
I can't thank you enough. And I just want to give a plug to, number one, a wonderful, wonderful speaker today. I learned so much, and I hope you all did. And secondly, the Cedarfield Forum will have its next meeting April 15th, the Tuesday, the third Tuesday, and it will be Barry Royden, a CIA officer, and his topic will be Cold War intelligence operations. So again, thank you.